Welcome back to the Hour and By podcast. My name is Nima,
My name is Aaron.
and today we're joined by a very special guest, Dr. Brennan, the director of the National Library of Medicine, a component of the NIH. Thank you so much for joining us.
Thank you very much for the invitation, and please call me Patty.
Patty.
Okay, Patty. Well, once again, thank you for joining us. And for our viewers, can you just tell them a little bit about your role?
I am the director of the National Library of Medicine. I've been here for now almost 4 years. The National Library of Medicine is one of the 27 institutes and centers at NIH. And each institute has sort of the same job. We stimulate new research either through our intramural research programs or through our extramural funding of research programs around the country. But the National Library of Medicine is special because we not only fund and develop research, but we also maintain the biomedical data banks, the literature resources, and the genomic repositories for the entire world. So unlike other parts of NIH who spend about 80% of their funds distributing to research projects around the country, we spend about 80% of our funds at NIH bringing you PubMed, GenBank, clinicaltrials.gov, dbGaP, and the rest of our funds we do spend stimulating new research ideas. My job as the director of the National Library of Medicine is to make sure we're well positioned to meet the knowledge needs of the country, citizens, clinicians, researchers, health service and health policy investigators. We also are, though, my job also involves me as part of the NIH leadership team. The 27 directors meet together every week with Dr. Collins to plan how to best position the National Institutes of Health to respond to the health crisis in the country and to accelerate knowledge and discovery.
So how has the National Library of Medicine become the gold standard of a reliable and trusted source of health information and biomedical data throughout the years?
So I love to tell this story. We are older than NIH. And we actually began very, very, very long time ago, 1838. We had an army field surgeon wanted to get some books in his field hospital so he could better take care of patients. So he wrote to the then Surgeon General, asked for funds, and received the support to get books in this field library. And that was the beginning of the National Library of Medicine. We began mostly focusing on medical literature. Around 1865, John Shaw Billings, who was really the first major director that made the library a library, started collecting and cataloging books. We're not really a lending library, but we're a repository library. Although if you can't find something, you can ask us if it's in our stacks and we'll copy it and send it to you. Over then from the period of 1895 till about 1995, we worked to bring technology, information, and health together. So we collected journals, we indexed those journals in something that used to be called Index Medicus. Now we make them available through the internet, through PubMed. We don't lend the journals, we do support the bibliographic listing so you can find the journals. But how do we become how do we claim to be the most trusted source of health information? We serve the public. We're a taxpayer-funded resource, and we systematically collect our articles, books, journals, information to help patients, to help scientists, to help clinicians. We use a variety of sources to do that. So we have specialized librarians who know how to identify and bring together the literature of the world. We have a literature advisory committee called our LISTRIC, our Literature Technical Resource Committee. This is physicians, nurses, library scientists, biological scientists, and even lay people who meet 3 times a year to look through all the journals that have applied to become a part of our collection and decide if they fit the quality of our collection. We actually only accept about 15% of the journals that want to be a part of our collection. But we already have over almost 6,000 journals indexed through PubMed. So our journal collection has been growing. We periodically monitor the quality of the journal. We look for editorial practices. We look for the quality of science as assessed by the scientific community for that group, whether it's nurses or biophysicists or what have you. We also provide consumer information for lay people. To get access to appropriate consumer information, we bring together the Consumer Advisory Board from across the National Institutes of Health, every institute contributing someone, to review and make sure that we're collecting and disseminating to the public the most available, most relevant, and most interesting. Now, trust means not only that our information is good, but that it's going to be available. That's why we make great use of the internet, so it can be available to all people. And it also means that we will collect information unencumbered by biases or constraints. So our accountability to the collecting the proper information for health is to science and society. We don't make the decisions ourselves, we reflect society's goals.
So you mentioned availability. Mm-hmm. So before we were preparing for you, this interview, we asked some researchers around the country that what would they want to ask you? And a researcher from Johns Hopkins asked a question saying she would like to ask about the National Library of Medicine catalog and PubMed. She said they have the new publications, but some full text of old discoveries are not accessible.
Yes.
What is your response to that?
So this is a very good question. PubMed is a citation database. It is a listing of the bibliographic records of over 30 million articles, but it doesn't list the full text of that article. We work in close collaboration with the publishers who bring together the journals, make issues and volumes, and take care of the editorial work of deciding which articles should be published and which should not. They provide us with the electronic description of the article, but they hold the actual article, and you need to get it through subscription or through some other means, say for borrowing in a library. About 15 years ago or so, we became aware that the public actually was paying for the research that NIH did, and therefore the public had a right to access that information directly. And they shouldn't have to pay a publisher's paywall to read that article. So we began now, actually almost 20 years ago, to build PubMed Central. PubMed Central, or PMC as we call it, is a collection of the full text articles of the biomedical science that is funded by the National Institutes of Health and some other agencies, but mostly the National Institutes of Health. We have in PubMed Central almost 6 million articles that are full text, freely available, and easy to read. It's often a dilemma to our public, though. Why do we list things in PubMed that they can't get access to without paying for them? And it is a balance of our relationship between making sure the literature is discoverable and the literature is accessible. Recently, there's been a shift in our country towards open science and citizen science. And that pressure has said this past history of having a proprietary means for storing knowledge, that is subscriptions and journals, may not be the best for the future. We recognize that scientific communication is changing, but we also recognize that the publishers are important partners in this process. However, during this period of time of this great global pandemic, we have helped to work with the Office of Science, Technology, and Policy to make all of the literature related to coronavirus and COVID-19 freely available with no paywall. We work to broker a relationship, we work to broker an agreement among the publishers to say, for this period of time, don't hold those important articles behind a paywall, but let them be accessible. So now, in addition to the 6 million articles that we have in PubMed that are broadly articles that are federally funded research, we now are collecting a repository of almost 80,000 COVID-specific articles that can be freely available and freely used.
So speaking on COVID-19, it's obviously a novel strain of SARS-CoV-2. So with little information about this, how do you add the evidence-based research when it hasn't really been out long enough? Like, what's the process? Because, like it hasn't really been through, that process. I'm wondering.
This is a really good question also. And it gives me a chance to brag again about the National Library of Medicine. The first evidence of the coronavirus infections and the SARS-CoV-2 strain actually appeared sometime around between September and November of last year. The hot spot, the concentration area, of course, was the fish market in Wuhan, China. But we think there might have been some evidence of the virus elsewhere in the world. Between this early observation of this virus, now the clinical care started around early December. Our scientists worked with scientists in Wuhan to create the sequence of the coronavirus SARS-CoV-2 from Wuhan, and made that entire annotated sequence available through GenBank on January the 13th. So it's not a book, it's not a paper, but it does help accelerate science because the reference sequence could be available and used freely for the public. In order to make sure people know that's happened, of course, we have to have lots of different public relations and communications to get that out. We know that the journals are rapidly reviewing articles and getting them into press as quickly as possible. But even still, it can take upwards of a couple of weeks to get an article from and completed. First, the work has to be done. Second, it has to be written. Third, it has to be reviewed. And finally, it has to be put into production. And even if we accelerate that time from submission of a journal through the review process and to make it available to the public can take several weeks, even under the best of circumstances. But there's an alternative form of scientific communication that's emerging. It's actually not all that new. We saw it in the physics field years ago, and this is referred to as preprints. Preprints are descriptions or manuscripts that have been submitted for publication but haven't been completely reviewed. Preprint servers are repositories that hold on to preprints and allow you to review them and sometimes comment on them. Many authors believe their papers are actually better when they put them out in the open to have comments. And, eventually many preprints actually go on to archival journal articles. But what we're doing right now, we began just about 2 weeks ago. The National Library of Medicine is starting to index the preprints of work that is funded by the NIH related to COVID-19. So we're beginning to experiment with making these preprints discoverable in PubMed Central. The preprints themselves live on preprint servers like medRxiv or bioRxiv, you may have heard of. But what we do is provide an index so that those papers can be found. Now, many people are excited that we're beginning to look at a way to make preprints more accessible. But back to your question earlier about what's made us trustable, PubMed has a very well-known brand that says only refereed articles will be found in here. So we have a dilemma. How do we get articles, preprints discovered more quickly without contaminating our PubMed brand of being fully refereed articles? So we've taken a couple of steps, including we put a banner over the display of the citation in PubMed when it's a preprint that says very clearly in bright orange, this is not a refereed article, this is a preprint. We also, because so much of the use of our resources now comes from machine learning algorithms that are crawling through our database, we also put a toggle switch on each preprint so that the machine learning algorithm knows that it's a preprint, not a refereed article. So we're working to speed up the transmission of scientific communication, but we're also looking at new models of scientific communication.
So previously, I quote, you stated, health is not a spectator sport. Please speak more about what you meant about this statement.
So as a nurse and an industrial engineer, I've spent my career building technologies that help people better take care of themselves. One of the things that we noticed early on, and my early research began in the 1980s during the last major epidemic to hit our country, which was the AIDS epidemic. And what we learned is that the healthcare system is but a blip in a person's life. You come to the doctor, you go for a surgery, you have an emergency room visit, and even if you have a blip every week, you still only have a small period of time with that provider. And the rest of the time, you're by yourself. But health happens every day in people's lives. So part of our job is to engage individuals in caring for themselves in ways that is meaningful, congruent with their family values and resources, and something they're capable of. So when I say health is not a spectator sport, I actually mean two separate things. One is that regardless of how the healthcare system is designed, most of the time people spend by themselves. So we as healthcare providers have to remember that we have to engage those people, not just watching their own health, but actually enacting health. And the second is the empowering idea that by providing information and tools to people, we give them the skills and the knowledge that will help them better participate in the process of creating the health that they desire.
So you just mentioned that you did nursing as well as engineering.
Yeah.
So my first question is, how did that happen? And second, how has both of those, I guess, different roles helped you in your current role?
So I went to, I'm a lot older than I look. I went to,
You look great.
I went to nursing school. I graduated from nursing school in 1975. And I had wanted to be a nurse my whole life. My mom was a nurse. I wanted to be a nurse. Very common in the 60s that women took women-oriented professions seriously. So that's where I was going to go. And I was particularly engaged by psychiatric nursing concepts and mental health concepts my entire undergraduate career. So my plan was to become a psychiatric nurse specialist. And I knew that at the time in nursing practice, you couldn't go into a specialty like psychiatric nursing until you had worked in a hospital for a year. In some places, they still do that, actually. I don't know what I was supposed to learn in that year, but I went to work in a hospital and did my share before I went back to graduate school, to where I studied psychiatric mental health nursing. But before I even graduated, a very auspicious moment happened in my life, and I can to this day remember the moment. I was walking down the hallway at the University of Delaware School of Nursing, where I was an undergraduate. And you know how faculty tape or post articles for you to read? They think you'd be interested, so they put them on the board. And you know how we usually walk right by them, and we just... So this one caught my eye. And it was an article written by a woman named Margot Cook. And the title was, "What's this about computers, and what are they doing for the lucky few nurses that get to work with them?" So this is back in 1975. There was no internet. There was no IBM. There was no, frankly, we had things called a TRS-80. There was only big mainframe computers. So I read that article, and it just kept staying with me. Computers, what could computers do for us? What could they really do for us? So when I went into graduate school for psychiatric nursing, to my surprise, one of my research courses had us using computer simulations. And I was, again, fascinated by the idea that you could create a small world inside this computer and understand the possible future outcomes of a present day decision. As a psychiatric nurse, I realized that some of the hardest things to do were to make a choice right now to know what to do for this patient who's in front of you, who's upset or distressed or fearful, and figure out how likely is it that you're going to get to the outcome you want, that the person will be calmer, will feel safe, or what have you. And I thought, as I was in graduate school, maybe you could use computers to give nurses tools to make decisions so they could know in the moment, what should I do now to get this person forward? So my nursing practice, which was in med-surg nursing, critical care, and psychiatric nursing, was actually from the very beginning intertwined with technology. And I still have a license, by the way. I'm not the person you want at your bedside, but I actually still will, if somebody, for a public place and there's a need for a health professional, I'll go as long as there's somebody else there to help me. But I really wanted to, starting back in 1980, I just was sort of enchanted by how could we work with these computers. And I thought everybody else seems to know this and I don't. So I looked around for places to study graduate school, and I worked with a wonderful nurse at University of Wisconsin-Madison named Joy Calkin, who helped me sort out what was it I really wanted to study. Psychology of decision-making, the business practice of decision-making, or the processes to improve decision-making, and that's where I wanted to go. She connected me with the Department of Industrial Engineering, where there were faculty who were beginning to look at using mathematical models and computational models to help people make decisions. And I thought, I'm home, this is it. And so I ended up getting to engineering because it allowed me to study computerized decision-making. Now, it wasn't quite that easy. Nursing is not well known for having a strong math background, a strong math basis. And in fact, when I went to my undergraduate program, I was during the first day of, how you go to advising and they say, take this course and take that course. So the advisor said to me, we're going to put you in remedial math and you don't ever take any math again because you can't do it. that was fine with me. Remedial math was the one that met at 8 o'clock on Saturday morning, by the way, but it didn't bother me. It was one semester. So when I was ready to go to graduate school, I met with the person who became my advisor, and I said, I really am very interested in mathematical models of decision making. I want to figure out how to help nurses make better choices with patients. And he said, this is great, this is fine. But he said, first you have to take a year of calculus. And I said, I don't do math. We have to find something else. Well, just like grammar is the foundation of all of the humanities, calculus is the foundation of all of engineering. So I did have to go back and take calculus. And it turns out that I'm actually quite good in math. I just can't add. So I'm not very precise, but I did all right with it.
All right.
It may seem like nursing and industrial engineering are pretty far apart, but I'm going to tell you one last piece about them that is really important, and I discovered over time it was a great lucky choice for me. Both nursing and industrial engineering have the same philosophical basis. They both take the perspective that our purpose is to improve human function by providing that which the individual lacks and no more. So in nursing, we use the therapeutic use of self, dialectics, pharmacology to help a person complement what they already have and take them forward to where they need to be. We happen to use psychological models or biological models in nursing. In industrial engineering, we take a systems approach to look at how a business, a traffic system, a transportation model should operate. We figure out what are the assets, and then how do we enhance those assets through mathematics or computer simulation. So both of the disciplines that I have actually have the same fundamental philosophical foundation.
So you spoke about undergrad and going to the guidance counselor and all that. So let's go back. If we were to go back to your undergrad and speak to that guidance counselor, speak to your friends or teachers, who would they say? If we sat there, we're like, hey, who was Patty? What would they say?
Well, I had the wonderful opportunity around 1995 of walking into a room at University of Montana where I was going to do some work with some friends and seeing that guidance counselor sitting in the room. So I got a chance to talk with her about what that experience was. With people who knew me in high school and college would have said, I ask too many questions. I was the kid that at the end of class, when the teacher said, are there any questions? My hand would be going up right away. Everybody else is ready to get out of the room. 5 minutes, and Brennan is asking questions. They would say, I'm the second eldest of 10 children. I don't know how much you know about my background, but as the second eldest of 10 children, I learned how to be resourceful. And so I think people would say I was resourceful. I learned how to make things happen with not necessarily a lot of money. I learned I was really good at getting money for undergraduate tuition and then on in my research. So I guess they said that they probably would say I'm pretty good at getting money also. I also probably have a little bit of a reputation as a party girl. I'm not sure that I want my mother to know that, but
well, it's too late now. It's out there.
Well, bringing it back to the National Library of Medicine, what do you want to accomplish within the next couple of years, decades, and how have you been working towards this?
We are the library of the future, and that means that we must be able to understand, excuse me, I'm going to sneeze for a minute. We must be able to understand information needs and how to meet them with it in a very efficient fashion. So we have challenges that we have to, if you will, extend more out into the community. The National Library of Medicine supports something called the Network of the National Library of Medicine. And the Network of the National Library of Medicine is 8,000 points of presence around the country. Hospital libraries, public libraries, specialty libraries, and pharmaceutical firms. And they provide us with a connection, a touch to our community. What kinds of information do people need and how do we get it to them in a way that is responsive to their own needs and the way they process information? We are becoming increasingly digital. That means we rely on somebody else's network to deliver our resources. So when Hurricane Maria hit Puerto Rico and the internet was down for 7 months, they couldn't get to the National Library of Medicine. So I'm looking for a fault-tolerant National Library of Medicine. how do we make sure we can always be available regardless of the physical infrastructure that individuals have? I'm working also a little bit to make sure our building at the National Institutes of Health is a modern 21st century building. The workspaces that were built when our library was built, which is around 1960, were built for people sitting in offices. We had a huge reading room, a big catalog room, because people would come to look things up. Well, it's, in 2020, people don't come to the library, they come to the internet to get to the library. So we're looking at how to better repurpose our space, again, in terms of being stewards of the federal dollar. And I'm working very specifically to make sure the data resources of NIH are robust enough to address problems like pandemics. So librarians understand how to organize data and make it available. So that's really, we're expanding from literature to include data, images, all sorts of important new ideas.
Talking about the pandemic, you had previously spoken about the history of the National Library of Medicine and its delivery at a point of need.
Yes.
I mean, what better time,
right,
a statement that fits than now. When you heard about the COVID-19 and, at the beginning it might've been something, not so big, but then it grew and grew. What was the first thing that you came into your mind thinking of that statement that you made that, the National Library of Medicine is the point of need?
So interestingly enough, I was on a cruise through the Panama Canal when I first heard about COVID-19 or the coronavirus. I don't think we were using the phrase COVID-19. I did get off the ship, obviously. But my office had called to tell me it was January the 13th and we had released the first annotation of the virus. So what part of what providing information at the point of need is understanding how that information needs to be acquired. And very honestly, most people don't read a genome. It's something that's processed through computer systems. So our computer systems made the computer code and the tools to decode the genome available to the public. We work on a human-computer interface model called responsive design, so that no matter how you come to the National Library of Medicine's resources, whether it's through an iPhone or through an iPad or through a computer screen, you see a web page that is proportioned for the device you're looking on. So part of our work is to provide the technical infrastructure. Another piece of the technical infrastructure, very honestly, is how you're reaching us. If you're reaching us wirelessly, then we have to make sure we provide an efficient way of delivering our information. If we know you're coming at us through a larger internet portal, we might be able to send, for example, bigger picture files because the port is large enough to send them through. So we need to understand how we are reaching. Some of our work through our specialized information services provided information during crisis, particularly during environmental crisis such as Hurricane Harvey or Hurricane Maria. In those cases, we also frankly work with a number of other disasters and emergencies. We provide a lot of our materials already embedded in smartphones so that first responders who need to find out how to manage a toxic exposure have a small piece of the library inside their phone.
So how important is citizen engagement when it comes to the National Library of Medicine and, producing data and things like that? Because I asked a lot of my friends, I'm like, hey, I'm interviewing the director for the National Library of Medicine, and two questions I got were, well, what's that? And
what's that?
the next one is like, well, how do I find out information? So when you're, making these resources available, how important is the layman important?
So that's a really good question. Remember I said we're older than NIH. We became a part of NIH in 1966. So we had 150 years of serving the society. The clinicians, we were part of the Army medical system, frankly, so we served the service people a lot. And it was only in the 1990s that we really started to understand our commitment to serving lay people, to serving citizens, moms and dads, kids and such. And that was part of the wisdom of my predecessor, Dr. Lindbergh, who really said that in a good way that if we really want to change the health outcomes of the world, we have to get directly to the people whose health we're concerned about, not to the clinicians who are in between us and the people. But I will tell you, we are the best kept secret in the federal government. We are the most popular website next to the Social Security system in the federal government. And yet when I say I work at the National Library of Medicine, mostly people will say, oh, well, that's interesting. There was a commercial a couple of years ago about Intel Inside. That basically nobody really knows what Intel does, but everybody thinks of them as an important part of a computer. And then, they build the chips that are inside them. So I try to use that same analogy of we're NLM inside. So part of the way we reach citizens is our consumer information resource, which is called Medline Plus, is packaged in a way that a hospital's computer system can send us a short statement of the patient they're trying to take care of. 26-year-old woman who's having their first asthma attack and has serious compromise. And that can immediately draw person-specific health information, self-management information back to that individual. Now, what that patient is going to see is a printout maybe, or maybe a screen on a smartphone. Maybe not ever know that it was the National Library of Medicine that delivered that, but we would be right there inside doing that. The same as when you think about, there hasn't been a discovery in the world that has happened in the last 30 years that the National Library of Medicine hasn't been a part of. People look at our research data banks, they look at our genomic data banks, but when you see the Nobel Prizes going out, they don't go to the library that supported the research, they go to the person who used it. And that's part of what a federal service does.
What is one myth that's correlated with National Library of Medicine?
I saw that question when we sent it. There are a couple I'd like to share with you. One of them is that we're a lending library. So people think that we are the NIH library, for example, and there is a library on the NIH campus that actually lends books and papers out to people. We are a library, a library for the world. We're considered a repository library. We're one of 5 federal libraries. The Department of Transportation has one. The Library of Congress is one. Department of Education has one. Department of Agriculture, and us. And so we are actually charged with storing and preserving the knowledge of medicine and health in perpetuity. So when you look at our building, people look at our building and they think, well, that's a tiny little building. It looks like it's 1.5 floors, but it's actually 5 floors underground because we have vaults where we have miles and miles of shelving for journals from 1850, 1920, 1940. So we preserve. And I think people don't think of preservation as part of our work. The last myth I'll tell you about is there are 1,700 women and men that work at the National Library of Medicine. This is a big workforce. There are probably only 100 librarians. And we have 3 times as many computer scientists and 5 times as many biological scientists as we have librarians. So we're a library with not many librarians in it. And there has never been a librarian, someone who holds formal training in library science, as the director of the National Library of Medicine. It's up until I became the director, it has always been a physician. And none of us have had formal training in library science.
So when you started your healthcare journey, what were your goals? Like when you were done, before you knew you were going to be the director of the National Library of Medicine, what were your healthcare goals that you wanted to have accomplished? And how has the National Library of Medicine helped you come close to that?
So I actually was ready to retire when I took this position. So I thought my career was over.
Okay.
I had a great career. I got to do so many interesting things. I started in the 1980s working on how technology would help people better take care of themselves. So remember back to my stories about how can this technology help people make better decisions, better choices. And I was particularly interested in what we would call unassisted choices. That is, a mom wakes up in the middle of the night worried about her kid. Can we give her support at that time? Or a patient's been presented with 2 different approaches to treat her cancer. How do we help her think through her own values, what she wants in the future? So that was my thinking. How do we use technology to help people better take care of themselves? And I got to do that in so many different ways. Early on, we learned, and this is part of my nursing background, you need to go where people live to figure out what their health concerns are. So in our early studies, we would spend maybe a year visiting the homes of hundreds and hundreds of people to figure, where do you write down your doctor's appointment? What do you do with information when you come home from the clinic? Where do you keep medicine in your house? And we learned people have very robust and very meaningful ways of managing information. Sometimes they're also effective, which is good. But we also learned that technologies were being built that did not fit into people's lives. You think for a moment, where are the plugs in your house? And if the person who built your house knew how many plugs we were going to need, they would have put a lot more of them, and they would have put them a lot higher and never behind the sofa. So we started to realize that knowing a person, their skills, their capability, their knowledge base, their intellect, their preference in reading or versus hearing information was all important. Knowing the content we needed to deliver, whether it's about pathology or self-management, that was important. But where they were sitting, where they were when they got that information was also important. So the last 5 years of my career at the University of Wisconsin-Madison, we started to use virtual reality, an immersive virtual reality cave, so we could recreate every household in the world and study how information fit into the daily lives of people. So I got to do lots of really interesting things. When I was retiring, I had plans to work in a whole other area. I'm personally quite moved by making sure that there's adequate housing and sustainable food for everyone. So I wanted to move into social services and to work in social justice ministries. And this job, the job that I have right now, had never been open my entire career. I was in graduate school in 1984 when Dr. Lindbergh was appointed the director, and I was retiring when Dr. Lindbergh retired. So there was almost 40 years that I never thought about this job. And so when the job became open, I had friends who'd say, oh, you should apply for this. This would be a great job. You'd be terrific at this job. And I'd say, I'm retiring. I'm not going to do that. I have other stuff. I'm not going to do that at all. And what made me change my idea from retirement to taking this work on was the fact that I could do in this job what I had planned to do in retirement, which is when you're responsible for organizing the literature, you're responsible essentially for the way people define health. And if in my role as the director of the National Library of Medicine, I can incorporate into that definition of health social determinants of health, the issues of self-awareness, loneliness, employment, family structure, isolation, those are all pieces that are allowing us to expand the understanding of what is health. And so even though I had planned to actualize it differently, by improving health, I can improve the food chain. I can improve sustainable housing. So this job is really a continuation of work that I once was already committed to doing.
So as mentioned multiple times throughout the interview so far, National Libraries is a platform of discovery. What have you personally learned or discovered, one thing to mention, while working at the National Library of Medicine? And if you want to throw in any secrets, feel free.
So I have learned that there's a difference between indexing and cataloging, which is a very fine-grained distinction in the library community, where you make a list of something as a catalog and you attach that list to specific descriptors of an object. That's indexing. You can't have PubMed without both of them, by the way. You need the catalog and the indexing. Probably the thing I learned the most is that in order to create any kind of collection, you have to really describe the object, whether it's a genome or a sequence or a clinical trial or an article. And this process is called curation. And it's the most human intensive process that we do. Fully half of our staff their job is to attach labels to objects so they can be discovered by other people. And that was quite a surprise to me. I, like other people, thought you put books on a shelf and they're there, you can see them. But when you want to make things discoverable electronically, you have to have a very sophisticated model of how they're described and how the computer knows to search for them.
How important is it for you to give back to the healthcare community? And do you still, do lectures, things like that? Like, how important is that for you?
See what I'm doing today? I think it's really important I think my job now, very seriously, is to make sure the National Library of Medicine is the best and most useful biomedical resource in the world. And so by my everyday work, I can say, well, of course, I'm giving back to the healthcare community. But what I really have to do is listen to what the healthcare community needs. So at least once a month, I have a discussion much like this one, whether I'm talking to researchers. Next month, I'm going to be talking to people who are involved in healthcare delivery and health services. I sometimes talk to students, and I say, what do you want from us? How do we serve you better? And sometimes I learn, oh, we hate this interface. I can't believe you put that up. I get pilloried on Twitter every once in a while because people don't like something we've done. But more importantly, I need to listen because I need to know now how well are we serving, and tomorrow what should we be serving? And then I bring that back to work and talk to my leadership team about how we might address those issues.
So you mentioned at a speech at Stanford back in 2017 that National Library of Medicine should become the epicenter of data science. What steps have you taken in order for that to be achieved? What steps do you think needs to be taken?
So actually, that quote did not come from me. That quote came from Eric Green, who was helping to set up the transition plan from Dr. Lindbergh to the new director. And when they did a study about what the value of the National Library of Medicine, Eric said that the National Library of Medicine should be the epicenter of data science. And it's funny you found that quote. I particularly said that in California because I'm terrified of earthquakes. And when you hear the word epicenter, you really think of something destructive, right? So in some ways, I don't want the National Library of Medicine to be destructive at all. I really want it to do some really good and exciting and interesting things. But what it means, we've actually sort of shifted to talk about the National Library of Medicine as a hub. And this is quite an important distinction. When you think of epicenter, often we think about a great big cauldron and lots of stuff falling in it. So when the data science and the massive data revolution in healthcare started to happen about 10 years ago, people envisioned that we would collect data like we collect library books and articles. We would just hold them and make them visible. But in fact, first of all, there's too much data. Secondly, some of it we shouldn't have. Patient-level data with your name on it doesn't belong in a federal repository. And third, we cannot always tell today what data will be important to healthcare tomorrow. So we're very concerned right now about wastewater and the appearance of the coronavirus in wastewater. Well, I have to tell you, we have very few journals that address wastewater management in the National Library of Medicine, but we link to the other repositories of information like that. So when I think of us as the epicenter, I think of us as being the door that opens through which people can pass and connect to data, information, knowledge, expertise, mathematical tools, visualization strategies that allow them to answer their science. So we won't discover the next treatment for cancer, but we will provide the tools, the computational biology platform for it, the journal articles to support it. So we are the intersection of all that is needed for discovery. And that's what I think of as the epicenter.
So how important is it with your international relations to keep your own research and database up to date? How often are you dealing with resources outside of the U.S., and how do you implement that into the National Library of Medicine?
Very good question. We are part of the International Nucleotide Sequence Organization, and that means that between us, a group in Japan and a group in Europe, we maintain the entire genetic structures that are known in the world. so that anyone who's searching for a virus doesn't have to search for the American version of that virus, but can search across all of the repositories. So those international collaborations are extremely important to us. There are a registry of clinical trials called clinicaltrials.gov holds 300,000 trial declarations, that is descriptions of trials. Some are completed, some are ongoing, some are recruiting new patients to participate in them. And better than half of those studies occur outside the US. So if we're trying to help a researcher understand who else is studying his problem, our clinical trials repository has to show a global view. Now, this has come in handy during the coronavirus crisis, because the World Health Organization's registry of clinical trials has run into some technical problems, and they haven't been able to keep it as open. So every night we get a feed from the World Health Organization so that their trials can be discovered in our database, and we can make sure we can support, if you will, our sister organizations around the world. We do a lot of work in sub-Saharan Africa. We're supporting medical informatics training and medical librarianship training in sub-Saharan Africa. We're part of a team called DSI Africa, or Data Science Innovation in Africa, that's designed to build capacity for data science in Africa. So while we are a federal government responsibility and our accountability is to the US citizens, we recognize that health doesn't know borders. And as we strengthen our connections around the world, we improve our ability to support health in the US.
You previously mentioned that you might have the greatest, I quote, you might have the greatest idea in the world, but it may go nowhere if you haven't taken the time to build the partnership. Can you think back to a time where a partnership has helped you in the long run?
Absolutely. Again, back to patients taking care of themselves and patient information. Throughout the 1980s, I worked a lot in people's homes and tried to move my field of medical informatics to stop thinking just about professional users, physicians and nurses, which is where most of the emphasis of building computer tools for healthcare was going. And also think about the patient, also think about how that person was going to manage at home after the discharge from the surgery or before they went in to have the baby. And I like to give speeches, and I like to talk, and I give lots of clinical examples, and people were saying, oh yes, this is yes, of course it's important, but it's really important that we address the doctors first. And then many times the lens that people wanted to put over patients using technology was, how do we help them be better informants for their physicians? How do we make sure that they provide a better history or more accurate follow-up on the medication regime? But I spent a lot of my time in the late 80s and early 90s talking to policymakers. Now, this was the time that the AIDS, awareness of the AIDS and the self-management for people with AIDS was becoming very strong. Teddy Kennedy was in Congress, and he was a staunch activist for person-focused care, for ensuring that people had the tools they needed to live. So I spent a lot of time talking to policymakers about the missing link in clinical care and technology was the patient. And one day was able to give testimony to a federal advisory group called the National Center for Health and Vital Statistics. And I showed them some pictures of people's homes. And I said, when you're thinking about building technology in a home or having a person take care of themselves, I want you to see these pictures. And they are pictures of kitchen calendars with little flowers all around them, or pet carriers with diabetic supplies stuffed on top of them. Bringing realism into the story really helps. And so those partnerships help to then break down the barriers, because at the time, the regulations restricted patients' rights to access their own data. And through the work we did in the early 90s, we opened up that access and made it possible for people to have full access to their clinical records and have the tools to manipulate it. So the partnerships with people who shared a vision of health but needed it broadened a little bit are really what has been most effective for me.
So I have a question from somebody. Their question is, what advice do you have for us when we're trying to find out about more information and new research on COVID-19 and vaccinations? Now, my response was, there's, you have clinical trials and things you have to go through, but what would you say?
This is a challenging time for people to find out information specifically about vaccines. So the first question I would ask back is, how much does that person understand about biology and virology? If it's a person like my mom who went to nursing school in 1950 and thinks of vaccine as the polio vaccine or the measles vaccine, I would answer it one way. If it's a person who's had some higher level training in biology, I might go in a different direction. So for a lay person who has limited understanding of, or sophisticated understanding of biology, and that could be a banker, frankly, who's maybe really good in finance but just doesn't know biology, I would encourage them to use our resources like Medline Plus and to use the CDC resources specifically, because the whole federal government has sort of clustered around the CDC to be the point of information about COVID. So we don't have different stories coming out of NIH and the VA and such. If it was a person who has some ability to read the literature, I might send them to PubMed, which is open to anybody to use. But if you don't have a science background, it's kind of hard to really sort out what's useful in PubMed. We have a couple of guides of how to find information in PubMed, but like you pointed out earlier, what the newest articles in PubMed may still be a couple of months old. And so if you're looking, how do we find out today what's important about vaccines? So we know, for example, there's a story in the New York Times today. Although it seems illogical, none of the vaccines, none of the approaches to vaccinations are virus-based, and none of the treatments are viral-based, because what they're finding is the viral-based treatments aren't working with the coronavirus. Don't exactly know why. So helping a person understand that the vaccines may take a different approach than attacking the virus directly requires a little bit more framing in the biology of it. Yeah. Not everybody needs to know all that level of detail. But what people can understand is that discovering a vaccine and actually getting it out to 300 million people, which is what we'll have to do, requires us thinking about vaccines the same way we think about cars or toilet paper. These are important, complex tools that everybody in the country is going to need. And we have to find the right distribution channel to get it into every household or into everyone's hands.
Being a healthcare professional, how important do you think it is for all healthcare professionals to actually even simple thing of knowing what the National Library of Medicine is? I mean, at school, we go through schooling, whenever they want to teach us PubMed or stuff like that, all the students are always like, oh, I'm bored, I'm not interested. If you're not really doing research, like you won't really care to, go those places. How important is it for you to, as a student, learn from the beginning stages of your healthcare profession to even when you become a physician, nurse, and so on?
If I could teach one thing to the teachers that educate our pharmacists, physical therapists, nurses, physicians, it would be to teach students to be brave and ask questions. And then they'd have to go to the National Library of Medicine because they'd have to take the answer. Right now, we teach students to answer questions. We don't teach them to ask questions. So if we were to teach you to ask the hardest question you could possibly imagine, what's the most effective way to get over the cold, the flu or the cold, or how do I know whether giving surgery is the best thing for my grandpa who has a heart attack? Then the searching of the literature becomes a mystery, a scavenger hunt, and you have to learn to pull things together. And then you begin to realize that the literature gives you power. The literature alone isn't useful, but the literature in the context of a question, that's when it's powerful.
Beautiful. So in your latest post on the director's blog, you actually spoke about the 2020 graduation and the changes that are forthcoming. Can you just elaborate on that and what your message was?
Well, I'm a little tired of hearing that the world's a mess right now. The world is complicated right now. There's no question the world is complicated. Social justice is at great risk. Economic stability is under threat. Health for my mother is a problem. But I don't want to tell I don't want the only message going to new graduates that, wow, it's bad out there. Stay here. It's a little nicer. I want them to know that each of them brings something that's going to bring a next step in a solution, and that the pathway to using that might not be obvious to them right now. There might not be a job with their name on it. That doesn't relieve them of the responsibility of taking that knowledge and really trying to find a little piece of the world that they can make different and mobilize forward. It's very easy to talk to graduates when jobs are plentiful, the economy's growing, and there's a great confidence in the knowledge you have. But what we've done, especially with our medical informatics community now, is we have said, here's tools, go use them. But we don't actually know when they're supposed to be used, and we're not really sure how you'll know when the problem is solved. So we've moved from what I would consider being a solution-focused set of graduates to a construction-focused set of graduates. The graduates need to construct the future they're going to be a part of, not simply solve the problems out there.
So due to the pandemic, a lot of researchers around the world, they're all trying to figure out the cure, the treatment, vaccinations. What is your message to all the researchers, not even just to COVID-19, but around the world? What is your message to them?
Keep asking questions. Keep asking questions, because the questions will guide you to lines of reasoning. Now, there's a second kind of question I'm going to ask researchers to do, which is to question your line of reasoning. That means I initiate a wonderment. How about this? What happens if that? Does this virus look like that one? And then I do studies, or I do laboratory work, or I go to the National Library of Medicine and I read papers. And then I want the researcher to have a second level of question. Did I miss something? Did I ask this question in a way that was sufficiently comprehensive and addressed the full range of the phenomenon? We know well, sure, that much of our research has focused on men, has focused on Anglo men and Europeans. And so we need to question, do I have the right substrate to answer this question? Or would this question be answered differently if I looked at a different population or looked in a different way? So question one, what am I curious about? Question two, am I asking it about it in the most explosive, comprehensive manner?
So when your career is all said and done, even though you already thought it was going to be done, what do you want to be remembered for? When
my son is 27 years old now, and when he was 10 years old, we went to StoryCorps. Do you know what StoryCorps is? It's on NPR on Friday mornings, and it's a movement to get oral histories of Americans. So if you get a chance, Google StoryCorps. It's really quite interesting. They have booths around the country, some one in Washington, D.C., one in New York, but they also have mobile vans that go around the country, and they have a wonderful set of questions. Basically, StoryCorps is an opportunity for two people to have a conversation, to tell their story. So my son wanted to be the questioner. He wanted to ask me stories, and he asked me that exact question. And it totally caught me off guard. So now it's been 16 years and I have an answer. So it's better. The first thing he asked me, I was stunned. I thought, oh my God, what do I want to be remembered for? And I can tell you, I want to be remembered as the person that took a look at this fantastic growth in technology that's happened across my life and kept plugging at ways to make it useful for people to take care of themselves. I want to be remembered for bringing the patient's voice into the healthcare conversation early and often. But most importantly, I want to be remembered.
Perfect. Good point.
If the seats were switched here, what question would you have asked yourself that we haven't asked you?
I might have asked why. Why do you do what you do?
Why do you do what you do?
And I might have asked that because it would have forced me to really think beyond the instrumental value of what I do. And like everyone during COVID, I'm on Zoom calls 10, 12 hours a day, and I'm busier than all get out. Why do I do what I do? Right now, my work is really focused on three things. I want to be sure that we don't lose the value we could get of all the investment we're making in research in COVID. So I want to make sure the data remain discoverable and accessible for researchers to use from now on. Second, I want to make sure the questions are big enough. You know, many people are worried about where does the virus head come into the cell and what kind of membrane break is going on here and such. Those questions are really important, but that's going on in a person's body. And that person is part of a family, and that family is part of a community. So the questions about the right way to test for COVID, the right way to treat COVID, cannot be addressed only at the molecular level. They have to be addressed at the whole person level. So part of why I do this is I want to keep dragging the questions bigger. And the last thing, the reason why I do what I do is that the opportunity to be part of an incredibly well-respected and right now well-funded part of the government that's about good, that is truly trying to improve society, is an amazing way of expressing patriotism. And I would never have thought of myself as a patriot. I didn't, my dad was in the service and I went to 4th of July celebrations, but I never thought about being a patriot. But since I took this job, I'm realizing that I'm serving the country, and I actually am pretty proud of that.
That's awesome. Well, thank you so much for taking the time to sit down with us. We really appreciate it. Like Aaron said, we know you're very busy, so we really appreciate you doing this.
I really appreciate that.